Second white coat. Subscribe and like. Let's learn medicine together.
All right, today we're going to play detective. We're going to solve a clinical puzzle, following the clues from a single patient complaint all the way down to the cellular level to decode one of the brain's most aggressive tumors. Let's dive in. So it all starts with something that sounds pretty simple, right? A 63-year-old man has a new headache. But there's a catch. A tiny detail that makes a doctor's ears perk up. It gets worse when he bends over. You see, this isn't just any old headache. It's talking to us. It's giving us our first clue. Okay, so what is that headache actually telling us? This first clue is our way in, our entry point into the diagnosis. And it's all about one thing: pressure. Think about it like this. When you bend over, the venous pressure in your head naturally goes up a little bit. For most of us, no big deal, right? But what if there's already something extra inside your skull, something growing and taking up space? Well, the skull is a fixed box. That extra pressure from bending over has nowhere to go. And that's when the headache gets sharp and intensely painful. It's a textbook sign of increased intracranial pressure, or ICP. So, the patient's symptom led us to suspect something was going on inside the skull. Imaging confirmed a mass, a biopsy was taken, and now we get to the moment of truth. We're about to move from what the patient felt to what the microscope can prove. Let's see what that little piece of tissue shows us. So here's the setup. We've got an adult patient, and the scans show a mass in one of the cerebral hemispheres. Under the microscope, pathologists are looking for a very, very specific signature pattern. What do you think is the most characteristic telltale finding they're searching for? And there it is, glioblastoma, or GBM for short. This is a high-grade, really aggressive brain tumor, and its identity is literally written in the tissue. It has two unmistakable hallmarks, two features that you've got to burn into your brain: pseudopalisading necrosis and microvascular proliferation. You see those two things together and they just scream glioblastoma. But just memorizing those terms isn't enough. To really get it, you have to ask why. Why does GBM create this specific, almost dramatic scene on a pathology slide? The answer tells a story. It's the story of a tumor at war with itself. So here's how it goes down. First, the tumor grows like crazy, incredibly fast. So fast, in fact, that it outstrips its own blood supply. The center of the tumor, now starved of oxygen and nutrients, starts to die. That's our necrosis. So what do the living tumor cells do? They try to get away from this dead zone, piling up around the edges. And that is what creates this pseudopalisading look, like they're building a fence around a wasteland. And finally, in a desperate bid for more blood, the tumor starts pumping out signals like VEGF, which causes a chaotic, messy explosion of new leaky blood vessels. And there's our microvascular proliferation. It's this whole cycle of frantic growth and decay. Now, any good diagnostician knows you can't get tunnel vision. Yeah, GBM has a classic look, but there are other things, other brain lesions, that can sometimes be confusing. So you have to know how to confidently rule out the lookalikes. And this table here, this is your cheat sheet. It's gold. You see the pattern, right? Each tumor has its own signature combo, a key microscopic finding plus a classic clinical clue. For our glioblastoma, it's that pseudopalisading necrosis in an adult cerebral hemisphere. But for something like an ependymoma, you're looking for perivascular pseudorosettes, usually in a child near the fourth ventricle. And a meningioma, you're looking for semoma bodies. The what, the who, and the where all work together to point to the right answer. And if there's one place people get tripped up, it is right here: pseudopalisading and perivascular pseudorosettes. They sound kind of similar, but they are worlds apart. It all comes down to what the cells are lining up around. In glioblastoma, the cells are fencing off an area of death, that necrotic tissue. In an ependymoma, they're huddled around a source of life, a blood vessel. It's a simple distinction, but it is absolutely vital. All right, we've gone from the patient's headache all the way down to the slide and back out to the other possibilities. Now let's lock it all in. Let's boil this down to the absolute must-know, high-yield points that you can recall in a snap. Let's do a rapid-fire round. You see a case with an adult patient, a mass in the cerebral hemispheres, and the biopsy shows necrosis plus that wild microvascular proliferation. Your answer is GBM, period. Remember, pseudopalisading means cells around necrosis. That's our GBM. Perivascular pseudorosettes means cells around vessels. That's ependymoma. And those little calcified whorls, semoma bodies, they should make you think meningioma. These are the core connections. Look, if your brain is full and you can only remember one thing from all of this, let it be this: This is the core equation. Glioblastoma equals pseudopalisading necrosis plus microvascular proliferation. That's it. That's the definitive pathological diagnosis. Burn that into your memory. And that brings us to the final big picture question. We can now read this tumor signature. We understand its story of desperate, chaotic growth and its frantic call for new blood vessels. So the real question becomes, how can we use that knowledge to fight it? Could we target that chaotic vessel growth and starve a tumor? Can we exploit its own weaknesses against it? Answering those questions, well, that's where the entire future of treatment lies.